Hi everybody, I'm Sally King, also known as Menstrual Matters. That's who I am, not really important. I'm going to talk to you today about what I did for PhD research. So I've been researching menstrual health and associated rights issues for over 10 years, but I only finished my PhD 2 years ago, and this is the study that I did for that. So I interviewed half of the world's PMS experts. Before you get too excited, it's only 16 people. And that's both critical experts, so critical feminists, typically in psychology, and gynecologists and psychiatrists. I did include the sort of 8 out of the top 10 people who've ever written on PMS, so it was a good haul. I also spoke to 12 people who self-identified as suffering from PMS. I compared the way that they describe PMS. I asked lots of nice, gentle questions to everybody that really I was testing them about how well did their descriptions of cyclical experiences actually match the available data that we have on cyclic symptoms. I identified factors influencing the use of these discourses. Like all of us, we are constrained or enabled to use certain metaphors or not, to describe things in certain ways. And I used a methodology called Critical Realist Discourse Analysis, which looked at what people were saying and also how they say it. So it enables you to look at metaphor, stuttering, sort of expressions that are showing you that somebody's uneasy, for example. This is a 5-minute presentation. I'll just very quickly tell you my these are the sort of factual findings. So we have really good epidemiological data, contrary to popular sort of representations. There's quite a lot of data out there on menstrual cycle, cyclical symptoms, and it's quite good quality. It's large sort of population studies. And I just compared the studies that are in the right-hand column with what the people were saying. So very interestingly, the patients were far more accurate than these world experts in PMS. They weren't really accurate, but they were more accurate than the experts. What I found that clinicians, so that was psychiatrists and gynecologists, they were really talking about cyclical suicide. So as a previous speaker mentioned, suicidal ideation, very severe mood changes, the exacerbation of underlying mental health issues. They might have called it PMS or they called it PMDD sometimes, but really they were talking about very severe experiences and not what the general public, including the people I spoke to, would consider PMS, which for most of us means sort of more typical changes associated with healthy menstrual cycle, nothing underlying. There was a lot of exaggeration. This is very common when we see gender myths in particular. So you might see down on the estimated PMS population prevalence. So in technical terms in medicine, PMS actually the term PMS only refers to problematic experiences. So when you can't go to school, or you can't go to work, or you've got a really bad headache, anything like that counts. But the sort of period pain, the sort of cramping pain, typical sort of experiences shouldn't technically count unless they're stopping you from doing stuff. So as a result, we have the patient saying, well, everyone gets PMS. So what are you talking about? And the average estimation was around 90%, but plenty of people were saying 100% of people who menstruate get PMS. Whereas in studies, population studies, people who are actually have problems with cyclical symptoms, it's more sort of 8 to 10%. And then that 2.4% is much more like the sort of PMD, severe mood swings, which unfortunately gets lumped in with PMS quite often. In fact, PMDD was spoken about as if it was a worse version, a more severe version of PMS, which it is not. And perhaps shockingly to you, but not if you follow my work, none of these changes are hormonal. The hormones, no hormone, not serotonin, not estrogen, not progestins, cause any cyclical changes. They are caused by inflammation from the physical processes that are happening in your body, not hormonal. A good example of a study that differentiates things that we call PMDD, so these severe mood changes, is Romans et al. They looked at prospective, so studies looking at symptoms in real time, and they found that there wasn't any specific premenstrual mood change in people without PMDD. So in the general population, mood change is much stronger with the day of the week, and that's for men and for women, and that's Monday and Sundays because of the working week, than any sort of menstrual cycle related mood change. which kind of proves that if you're getting this cyclic, severe mood change before your period or sometimes during your period, you've probably got an underlying condition. So what were people talking about if they weren't talking about the available epidemiological data that we have about cyclical symptoms? So this is all derived from the data. It's an inductive process. And again, I was looking at things like metaphor, which proved very, very useful. And in short, for 5 minutes, we have these 4 themes that came out. I have written a book about this that's going to be out in January. So if you're interested in it, don't worry, you'll read all about it. The first theme was mind over matter. Definitely, I was seeing the psychologization of changes, all changes, including pain, including bloating, as if, so for instance, the PMS experts were saying, not only is PMDD bad PMS, but vice versa, that the physical changes such as sore boobs, swollen boobs, back pain were associated with a mental health issue. So they completely inverted the logic, thereby placing physiological normal menstrual changes as part of a psychiatric diagnosis. So shocking, to be honest. They also, I said, give me an example of PMS, and quite a few of them gave me examples of suicidal ideation or attempt. This is not PMS to 99% of the people who experience it. Snatch 22, it's a nice catchy thing, is this paradox that quite often they're positioning very severe cyclical symptoms, which in my experience are always indicative of an underlying health condition, as bad, normal, like the far end of a normal curve, that you have healthy menstrual physiology and changes here, and these underlying conditions are just at the far end. Not true. No data to suggest that. We have a 6 minutes. Oh, sorry. Do you want to finish? Okay, so these themes actually reflect gender myths. Here they are. These definitely compound with other myths, particularly racialized myths, resulting in things like people not being believed. So female and particularly racialized female patients, particularly talking about pain, being undermined, dismissed, not treated, not examined. And a lot of it stems from the idea that your hormonal body renders you unbelievable.